And it is a great pleasure to introduce our first speaker, Dr. Suzanne Cahill, as co-author of this report. Suzanne is a social worker by training and by background, and she completed her PhD at the University of Queensland in Brisbane on the area of family caring and dementia. She returned to Ireland, I can't remember, it seems like yesterday, but I think it's about 15 years ago, is it? 15 years ago, and she took up the position of the director of the DSIDC. And over the last number of years, she's been on secondment here to the Department of Social Work and Social Policy, and she's been leading up this Living in Dementia program, which is really developing innovative psychosocial interventions for people with dementia and focusing on person-centered care. And she's been a driving force behind the development and the production of this report. And she's going to present now the seminal key findings from this report. Thank you, Suzanne.
Thank you, Brian. The title of my talk today is Confronting Dementia in Ireland, Creating and Reviewing the Research Evidence Base for a National Dementia Strategy. As the Minister mentioned, the work was commissioned by the Department of Health and funded by Atlantic Philanthropies. This first slide just really shows the different organisations involved in this research that have already been mentioned before this morning. Now, I only have 15 minutes, so I'm going to run quickly through some of these slides, but particular thanks to the Atlantic Philanthropies for funding the work. Just an overview of the presentation. I'll be talking about the actual review itself, what was involved, the core actions that were taken, the type of methodology we used to arrive at the information we got, the key findings, just to give you a flavour of the findings, because they're all in detail in the report you all will have received this morning, and then a summary of the work. So just by way of setting the context for today's session, I wanted to play a clip from 2 interviews done with family caregivers quite recently. It was work done by our postgraduate students, in one case a PhD project completed by Dr. Emer Begley, and in the other case a master's student. And so we might play the first one there, please. This is the 3rd slide, and it's basically a carer talking about really the struggle she has dealing with the stigma of dementia and the financial cost of dementia, and then she puts in very graphic terms her experience. So Danny, if we could play.
It's a very hard job, and you're thrown in at the deep end. You don't have any backing. You're thrown into a rough ocean with no safety net or life jacket, and that to me now is the worst.
And then the second clip is from a different carer who's talking about the difficulties she is experiencing trying to access community services, and in particular public health nurses. So if we could play that one, please.
Oh, for God's sake, those girls are run off their feet. They are run off their feet. She told me she has 300 and something houses to do. I mean, she said if I ever want to ring her, but to try to ring them and see how that goes. Oh, for
Okay, so I think that just kind of reminds us of the difficulties family carers have in this country, and that most people with the dementia are in the community, and that these are only 2 of what we know are now 50,000 people providing care to a family member who has a dementia here in Ireland. So quite kind of, I think, vivid reminders. So just moving on, the actions we took in this work, these are the terms of reference: to review current and future demographic trends in Ireland, and to provide estimates of current and future dementia prevalence rates, to estimate to provide new data on the cost of care, the economic and the social cost of care, and my colleague Eamon O'Shea will be talking about this immediately after me this morning, to review current service availability. We weren't actually doing any new research per se. We were actually interrogating data sets to arrive at the information we needed. And to look at best practice models both nationally and internationally on dementia. Our methodology involved doing an extensive literature search, both looking at the local, the national literature, and also the international literature. Doing secondary data analysis, so looking at data sets. There were 5 data sets in the HSE, and other sets like the HIPE, the Hospital Inpatient Inquiry, the National Intellectual Disability Data Set, the Department of Health's long-stay activity statistics. So we looked at all of these, and they're all in the appendix of the report, to estimate what was going on. We also did interviews with experts here in Ireland, as well as experts from the UK, people like Professor Subi Banerjee, who has been involved or has led the UK strategy, and Professor Julian Hughes and Professor John Keady in Manchester. And then, as mentioned earlier, we took soundings from a very active and an advisory committee that met really over the 12-month period, virtually every month, for 11 times. 16 people, multidisciplinary, and very valuable input into this report. So in terms of what we find from the literature search, that there's about 35 million people around the world, so at a global level, 35 million people with dementia. About 7.7 of these are living in Europe. And then the task we set ourselves was to look at new prevalence data using the Eurocode calculations. We wanted to look at new estimates of dementia prevalence at a local and a regional level. And then we wanted to provide new projections on prevalence rates, looking at census data and looking through to 2041. This slide, there's a lot of data in it, but basically I just want to bring to your attention the key Sorry, I've skipped over. The key findings here, which are that, as the Minister mentioned, we now know that there's about 42,000 people in Ireland with a dementia, and that there's a gender difference with obviously a lot more women than men with dementia in the older age cohorts. In the younger age cohort, under 65, there's more men than women. And these are people with an early onset dementia. So about 42,000 people. This doesn't include the 700 people we know who have Down syndrome and an associated dementia with the Down syndrome. So these younger people actually place particular challenges on health service providers because we don't really have the services to accommodate these people. Obviously, the other group also place huge demands on health services. We also used the census data from 2006 to look at the spread of dementia across the country. And what we found was that the highest share of dementia is in the HSE West, averaging on about 1.13% of the overall population, Roscommon having the particular highest amount of dementia, and then in contrast Dublin North East having the lowest. Now there's very detailed information about this on page 35 of the report on the numbers of people in these respective areas that we now know have dementia, and it's very useful to have this information in order to help plan future service development. We used the census, the CSO's population projections to estimate future prevalence rates over time. So we used this data extending over that 35-year period. And what we have found is that, as mentioned earlier, that at a conservative estimate, we will have by 2041 about 140,000 people with dementia here in Ireland. So the biggest increase will occur after 2021, where numbers will increase by virtually every 5 years in groups of 20,000. So quite significant and quite, I guess, interesting data from the point of view, again, of reminding us of the need to actually get our act together and start planning services. In other words, the data shows that over the 30-year period here, the prevalence of dementia will have tripled, or more than tripled. So, just moving away from the prevalence issues, where do all these people live? We know that about 2/3 of them currently live in the community, 2/3 of the 42,000, getting back to that original figure, and about 1/3 are living in long-stay care at the moment. I'm moving on now to the second part of the review, which was looking at service provision, and in particular we looked at these three broad areas: primary and community care, general hospital care, so how dementia is managed in general hospitals, and residential care. So starting with primary care, our work led us to believe that dementia remains very much invisible. It's very hidden in our society, and that in general practice, diagnosis tends to be the exception rather than the rule, that GPs are hesitant about getting involved in dementia and about diagnosis. And we heard the Minister stress the importance of diagnosis, and we know it is so important. That there are no dementia registers being held by GPs here in Ireland, unlike in England, where 90% of GPs keep registers of patients with dementia, nor are there any financial incentives to get involved in this area. We know from the review that memory clinics are very thinly spread across the country, that there's only about 12, and a lot of these are in the Dublin area, and that there are places like the west of Ireland where we have the highest numbers of people with dementia, has no memory clinic. Family members report diagnosis is not well managed. This was data emerging from the National Dementia Summit that the ASI did earlier last year, that people were complaining that this area wasn't well handled. Here in Ireland, there are no public health nurses or community mental health nurses, or practice nurses indeed, who wear a dementia hat or whose remit is dementia specific. So in other words, these service providers are really providing services from the cradle to the grave and can't really afford the time oftentimes to work in depth with families where there is a dementia. That there's a great paucity of day centres and home care services in Ireland. And again, it was very hard in interrogating these data sets to find any information on dementia. We know that there's 30 dementia-specific day centres here in Ireland. And I was really most interested to hear Professor Knut Ingolden last night over dinner talk about the fact that in Norway there's actually 30 dementia centres for younger people, apart from all the other day centres, that there's 30 that are specifically designed for younger people in Norway. And we have no caseworkers here in Ireland working in the area, so no key contact person that families can get in touch with and who can kind of help them negotiate their way through the labyrinth of services. We looked at the situation about dementia in hospital services in Ireland in the review. We saw that prevalence rates are about 19%, and this is a figure lower than the European estimate of about 25%, but this work is dated, it's about 15 years old, done by Hickey and Clinch and Groark. It's been reported that medical conditions here in Ireland usually precipitate hospital admission rather than a dementia. Detection and assessment is poor, and this is work done by Dr. Avzal out in Beaumont Hospital, where he saw that dementia, he did a clinical case note review of older people and saw that dementia remained undetected. The length of stay of people with dementia, their outcomes in hospitals are quite negative. They have a higher mortality rate, they tend to be discharged more often to nursing homes, and their length of stay tends to be much higher than older people who are cognitively intact. In fact, 4 times higher, an average length of stay in hospitals of about 41 days versus 11 days. We know from work undertaken by Louise Nolan here in Trinity that the hospital environment is far from appropriate for people with dementia, and that there's a need for staff training. That the report done by DeSune and Manning pointed to the fact that about 95% of nurses in hospitals hadn't had any dementia training in the last 5 years. And again, that people who have dementia in hospitals are very unlikely, even at end-stage dementia, to be offered palliative care. this is just a reminder of what hospitals are like, and I think we know from just looking at this slide how inappropriate the environment is in terms of, you know, how cluttered it is, how clinical it is, and how unfriendly it is for a person with a kind of confusion and with sometimes challenging behaviours. Again, I'm just going to play a quick clip from a caregiver whose mum was in a hospital for 2 months prior to her accessing, and in this case in Ireland it was a specialist care unit, and she describes, I think, very well what her experience was like. So Danny, could we maybe play that, please?
The hospital staff were very bad at communicating to us any tests they had done with my mother. Or like they did a test with her, say, in the middle of December. We didn't get that, the results of that, until she had been transferred to here. You know? They were very, very bad, and there was no communication amongst themselves, amongst the hospital staff. Really, really bad. Really bad.
Thanks for that. Again, it just, I think, is a chilling reminder of what goes on, and of course everybody is doing their best, but hospitals clearly aren't geared for dealing with people with dementia. I want to move on to the third area now, the residential care, and what we found in our review. We found that about 2/3 of people in long-term care have a dementia, and this figure is a lot higher than the figures reported in the official statistics from 2009 from the Department of Health, where it's estimated that only about 26 people in Irish long-term care settings have a dementia. And we're convinced that these figures are much more in keeping as well with European data, prevalence data on dementia in long-term care. We found here in Ireland that there are very few alternatives to the nursing home model. So unlike overseas countries, unlike countries, say, like the Netherlands, where there's about 5 different long-term care options for people, from clustered living to group living to specialist care units in care homes, specialist care units in nursing homes, we have a very, very limited range of care options. Only 14% of public units have dementia beds, 21 out of 151. There are a few dedicated specialist care units in the private sector, and that data is based on a survey work done by Nursing Homes Ireland from about 2 years back, where in fact we need to interpret it carefully because there was only about a 20% response rate to the survey. We know as well that the quality of life of people with a dementia, particularly people with a more severe dementia in long-term care, can be quite compromised. And again, in interrogating these data sets, we found it really impossible to get information from HICWA on dementia, on the numbers of dementia-specific units there are here in Ireland, and on anything to do with dementia, in fact. This just again is a kind of stereotypical view of residential care, and I hope and I'm convinced that we have moved away from this type of approach. The review involved us looking at best practice, as I mentioned earlier, right across Ireland and at a European level. And we saw, and I would have plenty of slides, I've only put this one up, of examples of best practice in Ireland, from nursing homes developing very nice therapeutic gardens, to their customising their environments to make them much more dementia friendly, separate rooms for separate functions, queuing, signage, well-trained staff, etc. The Alzheimer's Cafe, which is a new movement here in Ireland, which has started up recently. A reminiscence project where here in Trinity we were involved in a study which involved training family caregivers and bringing their relatives with dementia in and doing reminiscence work with them. There's also other excellent examples of good practice in Ireland, including the very, very valuable work being undertaken by Dr. Suzanne Timmins down in Cork, funded by the HRB, and looking at dementia in hospital care, looking at the family members' perspectives, the hospital staff's perspectives, and the patient's own perspectives. There's also very good work on palliative care going on here in Ireland, down in Clare, a palliative care project for people at end-stage dementia that straddles 2 nursing homes and a hospital. And very good work on daycare as well going on up in Dundalk at the Birches. So these are just a few examples of the good practice. Best practice internationally includes case management models, which are very much in evidence in countries like the Netherlands and being evaluated there and showing that they're actually cost effective. Dementia community teams. I've spent a lot of time in Sweden in recent years, and I've spent time with a Swedish dementia team. And they're really the Rolls-Royce kind of approach to dementia services. They liaise with memory clinics, with GPs, with hospital services, with nursing homes, and provide what's really needed to families to avoid crises really arising. Again, from our review, we saw that in countries like Scotland, in Australia and the US, that hospitals have appointed dementia champions, people who can take leadership of dementia in hospitals to help throughput, to reduce days in hospital and to improve outcomes. Again, we saw lots of examples of SCUs in the Netherlands, and we'll be hearing about the Norwegian Small is Beautiful and the approach to specialist care there later on today. And again, in the review, we saw that in the French plan, which we'll be hearing more about later on today from Florence Lussmann, that there's a big commitment to increasing the numbers of specialist care units across France, I think by about 12,000 in their plan, and that there would be special provision for people with very severe challenging behaviours in these units, and funding set aside to upskill staff as well. These are further examples of best practice. We looked in total at about 11 different dementia strategies or plans, and these are 6 of them. And in the interest of time, I'm actually just going to skip through them. But we found that each of these countries have a particular kind of focus in their strategies, and that we can learn here in Ireland a lot from the fact that other countries have well-developed strategies, and that we're really on the just starting point. I want to finish up by just highlighting the core areas that we see from this work are really important to the strategy. They include primary prevention, and here we're thinking about, we're referring to ways of avoiding dementia, delaying dementia. Earlier we heard the Provost talk about TILDA. There's very good data from TILDA pointing to high-risk groups in Irish society, that if we targeted educational programs at then, we may well delay dementia or avoid these people having dementia. So all the modifiable risk factors for dementia. So getting the message out that to look after what's good for your physical health is good for your brain as well is very important. Public awareness, really changing attitudes about dementia, destigmatizing it, thinking in a different way about it. So a move away from the kind of horror stories to more positive approaches to dementia. And of course the importance of training, and the Minister referred to this earlier, training, it's so important, upskilling staff, not just once-off training, but ongoing training and multidisciplinary training, training everybody. An increase in early diagnosis, again the Minister referred to this, through improving linkages between GPs, hospital services and memory clinics. The development of case management models we see is critically important to the new strategy. Having that key contact person who is involved from the early stages in doing the assessment, in actually developing the care plan, in referring the person, in liaising with day centres, and then later with long-term care staff. And then the expansion of dedicated community-based services. We really know these are needed here in Ireland. Good daycare that's dementia-specific, daycare for younger people as well that really fits their needs, which are quite different, and good home care packages to keep people in the community. And these last points, the development of new and expanded psychosocial approaches, which the Minister has already referred to, the development of more small-scale specialist care units here in Ireland, appropriate services for people with dementia, particularly those with early onset, and improved information systems. One thing we found in doing this review was that information systems were quite limited and very difficult to get good data on dementia, reliable and valid data on dementia. So just to summarise, our new estimates show that we now have 42,000 people, 26,000 of whom are living in the community. By 2026, these figures will increase to 67,000. This represents a 64% increase from 2006. And by 2041, to 140,000. And as I said earlier, that's a conservative estimate. It could be as many as 147,000. The most marked increase in dementia will be in people in the old age category, people over 85. And so all of this means that there is an urgent need to develop a really good plan and develop a dementia strategy. What we've achieved so far is through the review, we've got really convincing evidence that the baseline profile of services is low. The next step is to formulate the strategy, and this will actually broaden and deepen our work that we've done. We need more in-depth consultation with people with dementia themselves, with family caregivers, and with other key stakeholders. Our work wasn't the strategy, it was purely the review. We need a sustained and focused approach with a coalition between the main advocacy organisations, the Alzheimer's Society, Age Action Ireland, all the main advocacy groups, and professional groupings for dementia care, so that our strategy will draw wide support from everybody, and we believe that this is key to its success. So just to conclude, we must help, in my view, to create an Ireland where the public at large are better informed and better educated about dementia and the risk factors for dementia. We need to have an Ireland in the future where differential diagnosis of dementia becomes the norm, as does diagnostic disclosure, which is not well done here in Ireland as well, and we have research that shows evidence of that. We need to change the thinking about dementia, to dispel the myths and the stigma and the negativity, and to change it so that people can live well in our society and are supported. And we need to ensure that people with dementia die in dignity, assure that their needs are met by staff who are well trained both in dementia care and gerontological nursing and in palliative care. And I just want to acknowledge the co-authors of the work, Professor Eamon O'Shea and Dr. Maria Pearce, and other people from the LID programme who have been instrumental in helping us with this research and work, Caroline Forsyth and Vanessa Moore. And I want to leave you with the words from this is an article just published in the last week in Ageing and Society about dementia in Australia. And it involved interviews with family caregivers. And this is one carer who had been allocated a caseworker and what she said. So thank you indeed.